thank you to everyone for coming, and for those who are listening online to our IHPI seminar, the second of 2015. We're really privileged and happy to have both Angie Fagerlin and Brian Zikmund-Fisher here to talk to us today. I'm just going to briefly introduce both of them, and then I'll turn the floor over to them. So Angie Fagerlin, Ph.D., is the co-director of the Center of Bioethics and Social Sciences in Medicine, as well as an associate professor of medicine at the University of Michigan. She's also a research scientist at the VA Ann Arbor Center for Clinical Management Research. Her training is in experimental psychology, primarily in the areas of cognitive and social psychology. She's the author of over 100 articles, and her research focuses on testing methods for communicating the risks and benefits of treatments to patients, especially to those with lower literacy and numeracy skills, as well as testing how patient decision aids can affect patient and physician communication. Her research has been funded by many different groups, including the VA, the National Cancer Institute, the NIH, and the European Union, and has often focused on prostate and breast cancer, although since Angie is a psychologist, she's more interested in communication and those aspects as opposed to specific diseases. So thus she's also worked in areas such as diabetes, end-stage kidney disease, stroke, and pandemic communications. Brian Zikmund-Fisher, Ph.D., is an associate professor in the Department of Behavior and Health Education at the University of Michigan School of Public Health. He's also a research professor in the Department of Internal Medicine. He's also affiliated with the Center for Bioethics and Social Sciences in
Research
Medicine,
professor
the
or
Risk
research
Science Center
associate?
and Health Informatics Program, all at UM. He received
So you
his
got a
PhD
promotion.
in
I didn't know
behavioral
that.
decision theory. That's a combination of decision psychology and behavioral economics. And he uses this interdisciplinary background to look at factors that affect individuals' ability to use data to inform their health and medical decision making. He's an author of over 85 articles and book chapters, and he researches the determinants of patient risk perceptions, how best to display health risk statistics, and test results to make them more intuitively meaningful, the effect of poor numeracy on the use of health data, and the power of narratives in health communication. He's also worked in a variety of topics, including vaccination, diabetes, genetic testing, dioxin exposure, and cancer prevention, treatment, and survivorship. So you can see that there couldn't be two more ideal people to talk to us today about numbers. It's not just what you present, but how you present them.
Thank you. So now that you're all asleep, no reflection on Elizabeth, but those are just, do we want to save? Well, thank you guys all for coming out today. We want to talk to you about, we saw a lot of tweets going around, especially from Chris, saying that we're going to talk to you about how to communicate your study findings. And we're kind of going to do that, but more to how do we communicate study findings to patients, less to journalists, less to other scientists. That's a whole nother topic, and we'd be happy to do that at some point. Move this down so you don't go deaf. So there are many challenges to communicating information to patients. Now, one part are challenges in terms of literacy. How do you communicate words to your words to people in a way that they can understand? And this is really important because a lot of times we use a lot of jargon, a lot of big words. And you can imagine when somebody's getting a brand new diagnosis, they're not gonna know a lot of the words, a lot of the treatments, the diagnoses, the procedures, etc. And so we have to be really careful about how we, thank you, Brian, how we communicate in words. But we don't do that, so there you go. Now you know you gotta use plain language when you're talking to your patients, but that's all we're gonna say about literacy. But what we're going to focus more on today, as you might expect from our title, is numeracy and how to present numerical information. And this is a significant challenge to patients in understanding what kind of treatment to get or how to take care of their health. And we're going to go through that with you today. So I want to kind of put numeracy in context with you. And since I was worried you'd still be asleep from the introduction, I want to ask you, what is a bigger risk, 1%, 5%, or 10%? It's not a trick question. Anybody? Nobody? Wow, I thought our colleagues were smart. Anybody? Anybody? Right, it's 10%, right? This is really easy to know, and we're laughing about this. But the fact of the matter is about 22% of college-educated adults, when asked this question, couldn't get it right. Similarly, for this question, it's even worse. 1 out of 10, 1 out of 100, 1 out of 1,000. I know you know the answer, but about a quarter of college-educated adults, people with bachelor's degree or greater, which you can imagine what that number is for people who don't have a bachelor's degree, who don't have a high school education. So when we think, hey, if we just write down numbers, if we just give people numbers, we've done our job, we've done our due diligence, they have the numbers, they're going to use them, that's all we got to do. Unfortunately, it's not that easy. But then again, nothing in science is that easy, right? And so we wanted to show you all the many examples of how numeracy is important in medicine. The first one, and my favorite because I have little kids, is saying, in the middle of the night, it's 3 o'clock in the morning, your kid's screaming, you're trying to get the medicine. You know that your kid is supposed to get a teaspoon of medicine. What do you grab? And are these different? And there's been really good studies actually showing that people are grabbing a teaspoon from their drawer, sometimes a tablespoon from their drawer, and giving their kids too much medicine because they don't know that there's a difference between a syringe of medicine, a tablespoon of medicine, and then obviously this is the same as a syringe. But that there is differences, and so people are overdosing because they don't understand the differences in what a teaspoon is. Similarly, Terry Davis in Louisiana has done really good work showing that a significant number of people who are especially very poor, less educated, have a really difficult time knowing how to complete their pill boxes. So when the instructions on the pill box says take 2 pills twice daily, they don't know how many pills to put in each box. And as you can imagine, this can have a significant implication on people's health if they don't take the right medication at the right times in the right dosage. You can also see in diabetes and insulin, you've got to know how to adjust your insulin, et cetera. So there's so many everyday occurrences where numeracy is important. Then in terms of cancer screening, there's many things that people have to think about in terms of the numbers. What are the benefits of screening? What's the greater likelihood of survival if you get screened? What is a false positive and what is a false positive rate? When do I start? What is the advantage of starting my breast cancer screening at 40 versus 50? Or should I have lung cancer screening? Do I smoke enough to be eligible? And how much benefit will I get by having the screening every year for 6 years? Similarly, the other end, when to stop screening? When is it no longer beneficial to be screening? So these are all things where people have to be able to understand the numbers and make decisions about whether or not to be screened. And then the easiest one is thinking about treatment decision making. Right? So you're trying to decide, let's say you have breast cancer or prostate cancer, and you're trying to decide which treatment you are going to have to help treat your cancer. You have to be able to look at the risks and benefits of each treatment and be able to figure out which treatment is actually most beneficial to you, or are they equivalent? And there's been some really good studies which have shown that people with poor numeracy skills were less likely to be able to look at tables or to look at figures and be able to determine from those numbers actually what is the best treatment option for them. And finally, clinical trials. There's been some good studies by Kevin Weinfurt at Duke, which has shown that less numerate people perceive more benefit from participating in trials, even when those trials have explicitly said there is no benefit possible for you. So, and there's a lot of questions. Is that hope? Is that expectation? Is it that they don't understand the numbers? But the fact is that lower numeracy people have a harder time understanding when clinical trials could be a benefit to them or not. So now we want to talk about a topic. So now that I hopefully persuaded you that numeracy is really important and that this just pervades every aspect of medical care, we want to talk to you a little bit about the concept that maybe sometimes less is more. So one of the key findings from our colleague Ellen Peters, who is now at The Ohio State University, is that lower numeracy people are often less able to recognize the key pieces of information when they're reviewing complex information. And especially when we start talking about risks and benefit information, that's really complex information. And so they have a harder time sorting through all the information. So let me show you a little bit about her study. She was interested, or they, I know Ellen, so I say she, but they, I always swear I wouldn't do that. Is that they had all these different characteristics that people might want to use when trying to decide about which hospital that they want to go to. And as you can see, some are really particularly relevant. Number of registered nurses per 100 patients, percent of timeline of guidelines for health care, heart attack care, or pneumonia care are followed. Those are really important when you try to make a decision about which hospital can give you the best possible care. Now, other things that are a little less important to your care, like number of visiting hours, or I think there was a food one, quality of food. Well, those things are really actually important in terms of your satisfaction. If you're asked which hospital gives the best care, those don't factor as much. And so they gave either this table, which is unordered. You see the things that have about care are intermingled with the things that are less involved with care. And then she gave this table with just, it's that. That's what it is. I'll just stay away from there then, sorry. These are just the 5 factors that were most important to doing care. And then there was a middle one where they ordered it from the things that were relevant to care to the things that were not relevant in care. And the main point that we want to see here is basically for the high numerate people, it didn't matter how that information was presented. They could go through it, they could look at it, and they could get most of the questions asked about the quality of care correct, regardless of how the information was presented. They could absorb it, they could understand it, and they can make correct decisions based on the information, because in this case, there was a correct answer. But as you can see for the low numerate individual, there's quite a big difference in their ability to understand the information and to answer the questions correctly about which hospital gave the better care and what would be in their best interest to take. And so this is why it's especially important to think about how to present information so that low numerate people can benefit. And one thing that we've shown again and again is that a lot of the things that we do that helps the low numerate people, it either helps the high numerate people or it doesn't harm them at the very minimum. It either keeps them at the same standard or help. So a lot of people ask us, well, are people going to be annoyed? Are the high numerate people going to be annoyed if you give it, to focus it more on low numerate people? But it actually ends up being pretty similar. Okay, so how do we present numbers better? Well, let's go to this topic of less is more again. How do we communicate really complex information to patients? So we're going to use an example from Edge Event Online. And in this case, what a breast oncologist will do will enter information about a breast cancer patient's tumor characteristics. And they can give information about how the likelihood of being alive in 10 years or dying. And then it can, if you do nothing, and then it shows additional benefit by taking on either hormone therapy, chemotherapy, or chemo and hormone therapy. But that's really complicated, and it's really hard to digest. I'm sure your eyes are all bugging out when you're seeing this. But here's a much simpler format where you just present two items. And the reason you would probably do this is that for people with estrogen-positive breast cancer, there's really only 2 treatments. Most oncologists are going to really strongly recommend you do hormone therapy or hormone plus chemotherapy. So the other 2 options aren't as relevant for patients, so why even give it to them? Because it's hard for them to focus on what they should really be focusing on. And so that's why we narrowed it down to these 2. And we also did it because we like pictographs. We also did it showing it in pictographs. And what we found is that when people only had to look at 2 of the option graphs, they were much more accurate in understanding the incremental benefit that chemotherapy had on their likelihood of survival. So that was our key outcome measure, as we asked them one knowledge question: how much more likely are you to survive after a certain amount of years if you had chemotherapy? And when they only had to look at 2 bars, they made a huge, significantly different, were much more able to understand the information and pull out the key piece of information. And you look, it's much, much higher with a pictograph. And another study, we did look at even simpler, simplifying it even more, taking out all the other colors and just focusing on this, and this was actually much better as well. So sometimes including less information is actually can help the comprehension of the correct piece of information. And this is really important because a lot of us develop materials, or when we talk to patients, we're really focused on giving them as much information as we can. A lot of us have this high need for cognition, as psychologists would call it, or we're maximizers, and we want all the information possible. And while that might be really great, if we give people so much information that they can't gather what is the most important factors, then they're not going to be able to use that information in a meaningful way. So sometimes, truly, less is more. Another thing that we've been interested in is how to use graphical formats. And our goal has always been to help people improve their understanding of numerical information, and we wanted to figure out which graphical format to use. lots of people say, no, people will understand it better. Some people are more visual. And we know from psychology that you process visual information and verbal information in different parts of the brain. And you might be able to understand it better if you are activating both parts of your brain. So we were very interested in testing different methods of communicating information graphically. As you probably know from USA Today, there's a multitude of different methods that you can do. And so what we did in this study was we asked people, had them read through a scenario, and we asked them to imagine that they had clogged artery and they would need bypass surgery if their arteries remained clogged. We weren't going for a high degree of scientificness here, right? We just want to make this very simple for people. And then we told people that there are 2 people that they can take to unclog their arteries, and then it may help them avoid needing bypass surgery. We're very clever and creative, and after hours of debating, we called them pill A and pill B. And then we told them, like any good drug, there's going to be risks and side effects, and so we talked to them about what 2 side effects were. And then we gave them all that numerical information in one of 5 graphs, and because pictures are worth 1,000 words, I'm just going to show you them. So this is your typical bar graph. You'll notice that we did not put the number in. They had to figure it out from looking at the graph. Here's the pie graph. Now we had these really great research assistants who knew that we really hated pie graphs, and so they were concerned that we had not put numbers in to make the pie graphs fail. And so they said, one of the things that we're really proud of is they called it on us because we had a really good team dynamic. It said, look, we think you're trying to set it up to fail, so we want to make a clock graph because it's kind of a combination of the pie graph and the bar graph, and so we tested that as well. Then this is what it's called a pictograph or an icon array, and what you'll see here, it's a 10 by 10 matrix, and where the number of people are affected are highlighted in a color, and then those who are not affected are grayed out, but you can see both the gain and the loss, the people who didn't have an effect and people who did. And then this is what Edward Tufte called, I can't usually make my evil joke because Brian's sitting right here, but this is called the spark plug. This is what Edward Tufte has done. And it's basically the same thing as a pictograph, but it takes up less real estate on a web page, and so we thought it might be very beneficial. And then we asked people 6 knowledge questions. Now 2 of the questions, we wanted to see, are you getting the point that we're really trying to make? I don't care about numbers, but do you get the gist of it? So what drug is best at decreasing your need to have a bypass surgery? Or if you take one of these drugs, what drug is most likely to cause a negative side effect? So we asked those 2 just knowledge questions. Then we asked 4 verbatim knowledge questions, which was basically asking people to pull numbers out of the graph and make comparisons of those numbers. So they actually had to figure out the exact number that was being presented in the graph. So the long and the short of it, because I didn't get 20 minutes, is that pictographs won. So pie graphs were really good at communicating just information, but they were terrible at communicating verbatim information, which probably doesn't shock you. Whereas bar graphs were really good at communicating verbatim information, but terrible at communicating just information. But the one interesting thing was in both cases, pictographs were tied for number 1. They're just slightly less, not significantly less. So pictographs were really good at communicating both just information and verbatim information. And so this is what we've kind of stuck with since this study, and so in 2008. And what we found is that they're especially beneficial to low numeracy individuals. Now the other thing that the funnest study that we've done, and maybe not the funnest, but that we've always wanted to do for like a decade and we finally did it, was looking at, does the icons matter? Does it matter, because you saw in the previous we used squares. Everybody uses those smiley faces, and for what other crazy reason they drive me nuts. And so we wanted to do a study to see, can we say that they are bad and so they can stop using them? And so what we did is we tested all these different icon arrays. We tested squares and circles, or smiley faces and bathroom figures, and real pictures of real human beings. And what we found is that yes, pictographs do matter, the icons do matter. And it's actually the bathroom figures that work the best. So they are more likely to result in higher recall. People like them better. And they resulted in the highest correlation between perceived and actual risk. And there was no difference in this case among lesser, more numerate individuals in terms of these characteristics. So You'll see that those work really well. And we do actually have, iconarray.com is a website we have, so if you ever want to make pictographs for any of your clinical work or your research work, you can quick make these in about 12 seconds and be ready. And finally, the last thing I want to talk about is one of the benefits of pictographs is at some level it shows both absolute and relative risk. So I want to show you this. What if I told you a drug could reduce your risk of breast cancer by 50%? How many people would be interested? Sounds pretty good, right? Now what if I told you that this drug could reduce your 5-year risk of breast cancer or prostate cancer from 2% to 1%? Sounds a little less appealing, right? And it is, right? And this is a significant problem. And the research has shown again and again that people are really influenced by this information. That people will make decisions based on when they hear things on relative risk versus absolute risk. And we see this with patients all the time, but we also see it with physicians. There was a great study in the Journal of Clinical Oncology that looked at oncologists, and they randomized people to receive one of two journal articles. One journal article presented the benefit of chemotherapy using absolute risk. One presented the information using relative risk. Any guess which group of people are more likely to be prescribed the chemotherapy, the group who read the relative risk presentation or the absolute? Relative, right? So this is a bias that goes from the least educated to among the most highly educated people are able to be biased by this information. So what we like to say, it's very easy to remember. If you're trying to inform a patient, then you should absolutely always use absolute risk presentation. If you're trying to persuade people to do something or trying to get somebody to click on something on a website, then maybe relative risk is for you. But if you're really trying to help people make an informed decision, we would recommend presenting an absolute risk information. And now I turn it over to Brian.
So, Angie talked a lot about numeracy, about the ways in which people vary in their ability to think about numbers, in their ways to, that thing's gonna be, in the way that different presentations of numbers can lead you to have different understandings of the underlying quantitative information. I want to take it to that next step, and the transition point about sort of saying, okay, do you want to use relative risk? Do you want to use absolute risk? What is our goal in terms of what we as communicators are trying to do is relevant here, right? My primary appointment's in public health. And we are often in the business in public health of convincing people to behave healthier, to do things that we hope will make them have a healthier life. And the same techniques that we might talk about there as being useful things to get people to behave healthier, I take over here when I come over to CBSSM and go, wait a second, that's going to be a bias in the way in which we present information in the context of, let's say, a decision aid, in which we're not trying to guide people towards a particular outcome. We're trying to help them make choices that are in alignment with their own values. So what I want to talk about for the rest of today is, okay, let's say you've got a number, and you want to give it to somebody. Is presenting that number, even if we present it in the appropriate way, based upon the research that we have, is that presenting that number going to be enough to do what we want to do? So here's where I'm trying to go with this. I'd like you to start by imagining Robert. And Robert is your stereotypical middle-aged American, house, 2 cars, eats hamburgers, whatever. One thing that's probably true about your picture of Robert is he's probably packing more pounds than he used to. He's probably not exercising as much as he used to. In other words, he's probably not as healthy as he used to be. That's an unfortunate truth in today's society. At which point, Robert may well say, hey, I wonder if I have some degree of risk for cardiovascular disease. Maybe I don't know, maybe I'm at high risk. And so what do you do in today's world? Well, most people, what they do is they go online and they find one of these online cardiovascular risk calculators, of which there are a dime a dozen. And, Robert goes and he puts in his blood pressure and he puts in his weight, and he types it out and he puts in his real weight, and puts in all the stuff that the calculator asks for, and eventually he gets this. Your 10-year risk of cardiovascular disease is 11.22%. So let's imagine Robert goes out and talks with his friends. Let's say he has a barbecue or something. And they say, what'd you do today? And he goes, well, I used one of these online calculators and I put in all this stuff and it told me what my risk was 11.22%, but I'm still confused because am I at high risk or not? You see, let's assume for the moment that Robert used a cardiovascular risk calculator. Maybe it's based on Framingham data, whatever. Let's assume for the moment that that algorithm is the best algorithm modern medicine has to offer us. That his risk is, in fact, 11%. It didn't answer what his question was. He hasn't figured out what he needs to know from that. So we've got a problem here. There's a couple of problems here. Let's start with this one. Do we really think that that calculator calculated his risk to 1/100%? I mean, let's forget about the fact that he probably doesn't know his weight to that level of precision or his blood pressure or anything else, right? You would think you've got a data problem here. Well, yes, you do have a data problem here, but you also have another problem, which is by giving him that extra precision, it changes the psychology for him. And a few years ago, we did a study that showed that in a risk calculator type context, integer numbers were not just better understood, they were perceived as more believable and easier to recall. So why are we giving him that extra detail? It's not doing him any good. Now, Angie's already talked about graphics, right? We just gave him a number. We should be using a pictograph. We should be using something like this. But I'm just going to skip past this because we've already covered that piece. What I really want to talk about is the third problem, which is Robert's unmet information needs. What do I mean by that? The term of art in, this actually came out of marketing, but it's now very much in the decision psychology literature. The term of art here is information evaluability. And big word, but it's a very simple concept, and I'll try and walk you guys through it. So here's a Foxtrot cartoon from a few years ago, and it's got Jason who goes to the gumball machine and he gets 2 gumballs and he is ecstatic. He got 2 gumballs, this is awesome. And then he finds out he was supposed to get 3, and now he's pissed. Right? The 2 gumballs didn't give him an intrinsic value. The 2 gumballs were evaluated based upon his reference standard. When his reference standard was, I only expect to get 1, it was great. When his reference standard was he was expected to get 3, it was awful. But the same thing applies to medical data. Right? What do we expect? What are the relevant reference standards for the data that we are trying to communicate to patients? What Robert wanted was something that would give him an ability to classify himself. Am I at high risk? Am I average? Am I normal? Something that would motivate him to decide whether or not he needs to do something or not. What he got was a number that he couldn't change. He couldn't translate into that underlying meaning. And without that underlying meaning, he's left unable to use that information to guide his decision making. So let's try this again. 2.6% 5-year breast cancer risk. Gut reaction. How many people here think that's a high risk? Yeah? I notice a general lack of hands. Low? Neutral? No clue? Okay, this is well above the threshold for consideration for tamoxifen or raloxifene prophylaxis to prevent breast cancer. 5-year risk of breast cancer, those trials cut off at 1.66%. This is well above that. So from a clinical management standpoint, yeah, this is high risk. But many of you didn't get that. And that's, in fact, the point. Right? If I go online to a breast cancer risk calculator or a prostate cancer risk calculator, what I get is numbers. I don't get the interpretation always. Usually. Sometimes you do. So, for example, the National Cancer Institute's risk calculator gives you, and I've circled it down below, your risk, as well as the average woman's risk for that age. So that's one type of reference. Am I above average for someone my age? But is even that the most relevant reference point? Right? As I progress in age, everybody gets more risk. I could be average for my age and be at a high enough risk that I ought to be considering doing something about it. So maybe an absolute threshold might be a better reference point than what the average woman is. But either way, we got to start thinking about what are the standards we're giving people to help them compare and make sense of their data. See, Robert wants what I've called, I wrote a paper a couple years ago about different types of risk knowledge. And one term that I think describes this situation is Robert wants a category. He doesn't want a number. He wants to know, is he high or low? Is he average? That's what will help him motivate his behavior. And context is the key to this. He needs context and meaning. Now, how can we give context? Now, one way we can give context is by giving other reference points, right? If I want to compare surgery versus radiation, I can put them side by side. I can put them side by side with numbers. I can put them side by side with graphics. Any side-by-side evaluation provides an instant reference point. Whereas if I only gave you one of these graphics, well, is 75 good or bad? I'm not sure I would know. But we need to think about context in a much broader sense than this. Now, about a year ago, Vic Strecker and Angie and I and a variety of other people were involved in a project funded by the Robert Wood Johnson Foundation, which culminated in the following website, which is the Visualizing Health website, it was a project that allowed us to work with graphic designers to think about innovative ways of representing health data to try and make it more understandable. And I'm just going to show you one graphic from this because I think it illustrates the kind of thinking that we're trying to suggest. This is an output of a risk calculator. Now, the 11% is there, but the graphic structure here, the color coding, the step function, the giant flag in the middle that says, see your doctor, all of which emphasizes that sort of just emotional reaction of, hey, you're pretty high here, more so than the number. Now, whether this is the perfect graphic or not, I don't know, right? We tested this versus a few other ones. I think it may not be the perfect one, but it showed itself to have good characteristics as compared to other types of graphics. But from a design perspective, we made some very clear choices here. You might not remember 11% from this, but I'm going to bet you're going to remember that you ought to be worried. And in this context, maybe that's more important. The point here is that hard to evaluate data requires reference standards in order to be meaningful. Right? I know how to evaluate if I have to drive an hour to a clinic. I don't know how to evaluate a 75% success rate unless I have something else to compare it against. And if I don't have that reference standard, hard to evaluate data gets ignored. People make decisions all the time and they just simply ignore it. They base their decisions on something else. So if we're going to go through the hassle of giving people data, we got to think about how are we going to shape the way in which we give it to them. And this is particularly relevant when we start talking about lab results. Can patients use this? And by the way, this is a screenshot from my UMM Health. Well, what do we expect people to do? Right? Patient portals are giving patients direct access, i.e. they can get to numbers. But the value of that data comes from its meaning. And the first step to meaning is figuring out what is out of range. Right? So the only reference standard here is this, right? The standard range. So what's out of range here? That. Now, the question is, can patients do this? So, a couple years ago, we did a hypothetical study in which we took laboratory test results like this, gave them a scenario in which they were being tested as someone with type 2 diabetes, and asked them to identify, out of the set of test results, what is out of range here. Right? You want to talk about more nuanced uses of data, you got to start with here, because if you can't do this, you can't do anything else. We did this in a demographically diverse internet panel and measured health literacy and numeracy. So here's a set of stuff. Notice in particular, here's the hemoglobin A1C value, which I will point out is out of range. Can you find this? So we did two things here. We manipulated in the test results we gave across different subjects whether the hemoglobin A1C value was 7.1 or 8.4, or whether it was the only thing that was out of range versus one of many things that were out of range, to see whether that cognitive load would affect people's behavior. Now, I'm not going to cover all the results, but there's a few core things I want you to show you here. One is this. So let me orient you here. Low numeracy is on this side, high numeracy is on this side, low literacy, high literacy, low, high. What you see here is a pretty sharp slope in terms of being able to identify the hemoglobin A1C value as out of range. Highly numerate people and literate people, okay, Maybe we'd like to see that higher, but this was a web sample. Maybe not everybody's paying that much attention. But even within this sample, this is a 2-to-1 ratio, right? 30 to 65, 38 to 77, based purely on literacy and numeracy, controlling for other things. So less numerate, less literate people have a really hard time taking these types of test results and identifying what is out of range. And furthermore, it affects whether or not they decide they need to do something. I don't have the table here, but it affects their willingness to call their doctor because less numerate people are not even sensitive to what the numbers are. They're just sort of like, I guess I should do something. Whereas more highly numerate people are more nuanced in their responses. So if tables of test results are not the right way to be doing this, what is? What is our alternative? Well, we've got lots of things, right? If you go by what Angie talked about before, right, maybe less is more. Maybe instead of giving people all these numbers and tables, that look remarkably like that table of stuff that Ellen Peters used that nobody could understand. Maybe something more gist focused would work better. So, let me give you an example. Platelets, good or bad? Well, reference standard here. Standard range for platelets is 150 to 400. Okay? So we're out of range. So is it normal? No, it's not normal. But let me ask you this. Do we really care whether it's normal? Or do we care about some other things? Like, is it dangerous? Right, we're in the business of risk communication. I don't care what's normal. I care about what's dangerous. I care about whether or not this is something that you need to act on or not. And here's a nice little line graph. I've got context, right? Well, no, I don't have context. I have context related to what's normal. I don't have context related to what's dangerous. But if I were to tell you, as was told to me, oh, you know, you got to get down to about 50 before a surgeon's going to be concerned about doing an elective surgery, and you got to get down to something around 10 before you're going to be worried about spontaneous bleeding. I don't give a hoot about the 145 at this point. Right? And it's that other reference point that now provides the useful meaning for me as a patient to say, okay, maybe I need to talk to my doctor about this, but I sure as heck don't need to be calling him up at 11 o'clock at night. And if we're going to give patients these data, we might want to make sure that they don't feel like they have to do that. So how do we do that? So I have a grant right now from the Agency for Healthcare Research and Quality to try and tackle this problem. And I'm just going to show you an example graphic that starts to get at this with the same kind of less is more principles. Right? We got color coding. We've got blocks with labels that are evaluative, right? High versus borderline high. We've got something that is going to evoke that same sort of just emotional reaction like that cardiovascular risk graph that I showed you from Viz Health in the context of a laboratory test result. So the takeaway message of all of our talk, both Angie's and mine, ultimately boils down to this. Numbers are good. Numbers are very valuable for patients to make sense of data because patients can use data to help make complex decisions, to guide their health behaviors. But ultimately, having the right number is just the start of the process, right? You got to have the right number, and you've got to have it in a format that they can understand, and you've got to make sure that you haven't overloaded people with so much information that they can't process and find their relevant stuff. And you have to give them the reference standards or the labels or the context to ensure that when they have the number, they know what it means. Because providing context is the key to evaluability and meaningfulness. And ultimately, I don't care whether people walk around, I don't care whether Robert walks around knowing that he's 11%. I care whether Robert walks around knowing that he's at elevated risk. And so ultimately, let me leave you with this. More than anything else, remember that providing the right number, whether it's to a patient, whether it's to a journalist, whether it's to another clinician, is by no means a guarantee of the right message. And I think that's it. And Angie and I would be happy to take questions.
Andy?
Thanks, that's a fantastic talk. I think one thing that I struggle with both as a researcher as well as a clinician is providing information that is decision specific versus more generalized. So using your examples, one being looking at a portal and trying to interpret a routine annual physicals worth of lab results versus making a decision on surgery versus radiation for a cancer. Mm-hmm. And I wonder how you as a decision scientist and also how a clinician can use those two different types of information differently, both in terms of how you do the research as well as how you present it to patients.
Yeah, so I'm just going to sort of restate the question for the recording. You're sort of wrestling with the choice of, are things different when you're focused on sort of like interpreting a broad set of numbers in a screening context, an annual physical context, just sort of how do you think about that problem versus a very focused decision problem, whether it be choosing one treatment versus another or something like that. So my first thought is it's not actually that different, because what's common is that you have some specific goals in mind in each of those contexts. Right? In the decision context, you've got a defined option set. And whatever that option set, whether it's 2 choices or 3 or 4 or whatever, that's what you're forcing to choose between, and you must choose one of them. Or maybe you don't, and that's an option too, right? If it's not doing something as an option, then you can have that as an option too. In which case, your problem is inherently comparative. I don't necessarily need to know absolute levels as much as I need to know, is this better or worse than that, and to make those incremental differences, like in the adjuvant therapy case, really concrete and clear, because that's the key in terms of the trade-offs between your different options. When evaluating a broader set of information, let's say test results done in an annual physical, that's a screening context, right? We're using that to guide our attention. If it's okay, we're going to put it aside. If it's not, and that could be defined by any number of different measures, we draw our attention to it and then think about what next. And so the format of the presentation ought to align with that. Right? One of the things that my pet peeves is in the test result context, there's nothing in the patient-facing version that I showed you that is a high-low flag. Right? We actually hid whether or not it's above or below. The clinician-facing displays show that, but the patient displays don't. So what is the patient supposed to do with this? Why is the patient getting this? If the patient's supposed to only simply have it and not know anything about it, why are we going through the process of giving it to them? And if they are supposed to give something about it, then let's give them the reference point. And if that reference point is, call me if it's above X, then that's our goal. And so it's that goal-driven thinking that I think is the way we need to think about all these types of problems. You got anything more to add to that?
I do, but it's good enough.
Oh.
Just kidding. Dr. Monti?
Just a question on the practicality of like showing the UofMHealth.org data to the patient. I mean, the context not only is normal or abnormal or how far abnormal, but it gets much more even nuanced than that. If someone gets a CBC after surgery and it's 9 grams hemoglobin and it was 14 when they left the hospital, that's a lot different than if it was 9.5 when they left the hospital.
Yep.
Or if it's somebody else who comes in off the street. So I mean, adding that context to it gets really complicated quickly, I would think.
So we have a problem. If we don't provide context, we're giving people numbers that we can reasonably assume they can't use. So why are we doing that? If we do try and give them context, it gets tailored and complicated quickly. And I mean, in our grant, we're wrestling right now with the context of diabetes self-management, right? There's what the standard range is. There's what your long-term treatment goal is. There's what you would like to be at this test. Those 3 things may be very different from each other. All 3 of them are relevant reference points. My sort of ethical standpoint is I think we've left it too much in patients' hands and sort of left them adrift. And as technology improves and our ability to build systems that enable tailoring to be done in the display process, maybe we aren't there yet, but I think the complexity of the problem we can solve eventually, and I think it will make a difference in the long run in terms of enabling patients to use the types of data that we make available to them.
Almost doesn't it require some healthcare provider to make that context judgment?
Okay, but why couldn't the
Usually
healthcare?
almost, or often?
So why couldn't the healthcare provider at the time at which that test is ordered say this is what the threshold ought to be for you? There's a workflow issue that has to get worked out. But
Otherwise, why are we giving the numbers, right? Why are we making a big push to have people log onto their portals and to look at their numbers if we're not going to let them use those numbers in any meaningful way?
Because you're pretending that transparency is pushing.
I guess we'd like to not pretend.
Right, exactly. Because I think it's easy to give numbers, but if they're not going to help people and could actually potentially harm them, right? Either they're not understanding and they will not do stuff that they should be doing to improve their care, or they won't be able to react to really serious information and be calling the doctor. And so if it has no meaning, maybe it looks good for the health system, but it's not what's in the best interest of the patient.
Here's an example that I think motivates this for me more than anything else, right? In diabetes management, a 1% move of hemoglobin A1C is a big deal. 1% looks small to most patients, right? I think 1%, what's 1%? Right? And in many other contexts, it doesn't matter that much. But a 1% move of that value ought to be reinforcing. If a patient's going out and investing time and effort in changing their diet or exercise or taking their medications, we want to make sure that they see that as valuable, which means they need to get some kind of an emotional response from their test result data in order for that value to feel like, yes, I made a difference. And that's, even if they move to half a percentage point, they ought to get that. If we fail to do that, we run the risk that by providing them with the information and the direct feedback, it's not only neutral, it can be demotivating, and now we're undermining the very thing that we're trying to achieve. So again, it's sort of this conditional thing. If we're going to go through the process of giving people data, it feels like we have to somehow tackle the challenges, and they're real challenges, in order to make it have the meaning that patients need it to have.
Great presentation. A lot of what you presented was what's the evidence base for improving understanding of data, of numbers that we share with patients. Can you take it a step further and comment on the evidence base for actually changing behavior? Like, for example, if your cholesterol medication example, are there studies that take it the next step that show the way you presented the data influenced, someone's actual cardiovascular risk based on how they responded?
I think that oftentimes that's a limitation of the grant funding system. So for example, we'll work really hard at communicating information, but it takes so long to do the intervention that by the time you can see health outcomes, the grant has to be over, right? And so I don't think, I'm not thinking of any that have shown specific health outcomes. So we show, we can show that different ways of presenting. So in my prostate cancer work, presenting things in a more simplistic way with more plain language, more graphs, more tables, motivated people to want less treatment. They wanted more likely to do active surveillance. It motivated them to want to be more involved in the decision. But then when they went to see their urologist, a different decision was made afterwards. So, before they did, it had an impact on their decision making, but then that was wiped out by whatever happened in that clinical context, for better or for worse, right? There could be very good reasons why it changed. There could be less good reasons why it changed. Right, Dr. Monti? And so I think a lot of these studies are not done. I think that's what Dr. Monti was getting at, is that there's a big role for the provider. And so a lot of these are then confounded by providers interpreting the information in a different way. And so even if we do find differences based on our interventions, they're very easily wiped out by recommendations from the physician.
I would want to add one piece of this. Your question asked sort of about the relationship between these types of communication interventions and health outcomes. And I don't think there is as much data as we would like in that. There's a growing amount of data connecting numeracy with health outcomes, not just health knowledge. The one that always sticks with me is anticoagulation control.
Yeah, that's the best one.
And it's not literacy, it's numeracy. Even health literacy doesn't seem to have as strong of an impact as numeracy does on people's ability to maintain and titrate and change dosages, et cetera, to maintain anticoagulation control. We see this in asthma, we see this in a variety of in diabetes, and so clearly there's a relationship between that number management skill and health outcomes we care about. We know that step from presenting things in a clearer way to knowledge, because our work shows that link to be quite tight. We do need to fill in the each step along the way, but I don't think that's too far in the future, because even just in the last 10 years, what we've known about the link between this number skill and knowledge, then going to behaviors, then going to outcomes, has really been strengthened.
But Tanner, actually, kind of relevant, Tanner Cavalry and some people over also in the hospital, I think Doug Ehrenberg, have been showing people the numbers related to lung cancer screening. And when people see the absolute benefit from lung cancer screening, which I believe is something like 0.33% increase in survival after 6 years or what have you, people's interest in lung cancer screening goes down. For better or for worse, right? I mean, we can make arguments that, so one of our...
The persuasion versus decision-making piece. At what point is the information a persuasive tool versus an informational one?
Right, and in this case, it's probably persuading people in a different way than had been thought. So I think, but then what happens is, so when they see it, I think people are really struck by it. But then we'll see what happens when they talk to their physician who really wants them to get screened, because they know that lung cancer screening is probably one of the more effective cancer screening tests that we actually have. And so, so that's where it gets really complicated really quickly. But
and I'll just close that loop with a different project that's going on. One of the things that I'm working on with Samir Saini is about how do we talk about cancer screening towards the end of the lifespan. Colonoscopies for 75 or 80-year-olds when it really is no longer recommended based upon the risk-benefit trade-off. What we know qualitatively is that there is at least a subset of patients who feel like they've been told over and over again you're supposed to get screened, and then feel very like they don't know why you're not asking them to get screened again. What hopefully this project will show is if you present this type of information using the principles that we've been talking about, to really make that evolution of the risk-benefit trade-off more clear to them, that we will see better, more sort of value-congruent screening decisions through that age span. We'll see what the data say.
Michelle?
Can you talk a little bit more about this principle that less is more within the context of preference-sensitive decisions? So, for example, I'm an OBGYN. I talk with patients a lot about contraception. There's 15 options. There's a lot of numbers. Things that are most important to me may not be most important to the patient. I talk with patients about options for genetic testing, screening versus diagnostic testing. There's a lot of math and a lot of new concepts, but from my perspective as a provider, I feel like for a patient to make a really informed decision, I do sort of have to present a lot of different options. It's hard for me to tailor that or restrict that information. So do you have advice for how to handle that in a preference-sensitive way for patients?
Yeah, I've thought a lot about the contraception question. So actually for the recording, she's wondering, there's a lot of information that you need to present. How do you make less is more with doing it in a preference-sensitive way so that we're not kind of telling people what they should get and not get. And I think there's different ways to do it. Some of the matter is that you do have to often present a lot of information. Some of it is you can help them think through. So like I'm thinking of bedsider, where you start asking them about their values related to things to help narrow it down. So some things may be really relevant for one group of people, but not so relevant for another group of people. And so you can start narrowing it down to what information that they need. But then by also providing that information for the people who do want it. And I think that's an important thing. And you can do it also in terms of the architecture of the way of the information, where the basic things are shown first. And then if they want more detail, there's an opportunity to get that for people who want it, but that then people that don't need it, don't want it, can focus on the things that they are most interested in. One of the things that we found that have been helpful is actually summary tables that walk people through all the key components. So you can walk them through it separately and then put it in the summary table. And we've actually found that to be a really effective way to kind of help make it really easy to make the comparisons. Do you have any others?
No, I think the tiered structure is the key thing that I've certainly taken away from your work. That, you talked a little bit about sort of the fact that we haven't really found situations in which we need to do something different for high numerate people versus less numerate people, and this gets at this point. Right, the high numerate person could sort through the big pile of options, but they don't actually mind if you make it simpler to start, and then they can go hunting for the stuff that they haven't yet seen yet, if it's obvious how to do that. The less numerate person desperately does not want to be overwhelmed. By simplifying it at the start, by boiling it down again to that gist. What is the core thing that this person, maybe it's the values, which of these values is most important? Maybe there's one or two trade-offs that are the big ones, and then the rest of them only matter once you get down to a smaller subset of options. Either way, understanding the structure of the choice helps you narrow the process so that it makes it easier. And to sort of reinforce this, there's another study that we didn't talk about, again, done in the adjuvant context, in which we just traded off presenting 4 options versus all the sets of information. We didn't even take any information away, but just doing it in terms of a series of binary choices. And what we saw in that study was that, again, the highly numerate people didn't really matter that much. But for the less numerate people, only when they had that sort of slower, 1 bit at a time presentation did they become sensitive to what the information was. Otherwise, their choices were just unaffected by the data.
Jeff?
In the context of less is more, thinking about a decision aid that's inherently built to be used by both a patient and a physician together, how do you provide something that gives the less is more benefit to the patient when it may be used either by a clinician expert who has the knowledge of all the numbers, or perhaps a clinician who's not expert and needs some of those numbers provided to them in case the question comes up? And how do you balance, what's the impact of a less is more aid from the physician standpoint as opposed to from the patient standpoint?
I think I would say that for whatever information a physician is going to need to be able to do that would be information you'd want to put in there anyway, because it must be pretty key, right? So I think I'm at least getting worried that when we say less is more, it means to be very, very minimal and hardly include any information, and that's not our message at all. No. Because these are complex decisions. There's a lot of information to give. But for example, there are details that are less relevant. So like the estrogen, the adjuvant one is a good one because some people, given their tumor characteristics, it's not even a choice for them. It's not even an option. So why are we presenting things to them that's not an option? But if people need to understand that this is an option, this is a risk and benefit, we want to give it to them. And a lot of people have been arguing that people don't understand numbers, so why even give numbers anyway? Why don't we just use words or say it's a small chance or moderate chance? And some of that is if there's anything that the psychological research will show is that giving words is about the worst thing you could possibly do, because as we all raised our hands differently about what 2.6% risk meant, it meant something very different to all of us. Well, even within a person, what a 1% risk is very different, right? A 1% risk of your arm hurting after a flu shot is a very different risk than a 1% miscarriage due to a CVS test, right? It's the same risk, but one number seems low, one seems high, and how do you use those numbers? And so in that sense, we're not suggesting that people take out numbers or try to minimalize it or try to get everything into one page, because I don't think for a lot of these health conditions that's possible. You still need to describe things, you still need to give the data. And if anything that you're going to want the physician to see, you're going to want the patients to see as well. So I wouldn't worry about it in that detail.
So I will agree with some caveats. Part of the point to make here is that it matters what your goal is, right? The adjuvant case, the whole point of adjuvant therapy is to reduce risk. If you don't understand the magnitude of the risk reduction, you don't understand the point. Saying that you have a low risk of recurrence doesn't cut it, right? The categories just are insufficient to guide decision making. So you have to have that information. You have to guide people to that more detailed level. That's a different problem than Robert's problem. Robert doesn't necessarily need to know whether he's 10.5 versus 11.5. He just needs to know he's high. So let's look at the difference in the situations. But even in the context of a decision aid, I agree with Angie, right? Too often verbal terms are too vague, too misunderstood between people and even within a person to be a useful way of presenting stuff. And part of this is the question of if it's a really relevant trade-off from the clinician's standpoint, it's probably relevant from the patient's standpoint. But it's also the case that we can remember some of these trade-offs are trade-offs that are in which small differences are going to really matter, and other situations are ones in which you just need to be able to understand the big differences. And that's relevant too, right? Sometimes we might want to color code stuff in ways that will highlight the trade-offs in different ways. Other times we might want to do it slightly differently because let's say 1% difference doesn't matter, but a 5% difference does. So it's hard to sort of have a hard and fast rule about whether you should include numbers or not. My general principle is, if you, as the expert, were in that situation, what is relevant and what's not relevant? And be willing to let some of the stuff that's not relevant take a secondary place in the presentation so that you reserve people's attention for the stuff that really does matter.
So I want to add two things, and then I think our time is up. So Brian and I tend to disagree on this. This is one of our topics about the importance of information. So that's why you see a disagreement, because I guess even friends disagree sometimes.
Shock.
But the other thing that I would say is when you're developing this and trying to figure out what information needs to be presented in these tools, we shouldn't be making those decisions unilaterally as educators, as designers, as clinicians. This is where you talk to patients, you talk to clinicians, your stakeholders if you're writing up a Corey grant, right? You talk to people about what information is important to them and what isn't, and what is too complex or too, so sometimes, like Brian and I will disagree about whether something should be put in as a number or the gist is different. So if we can't even make those decisions together, maybe we should start talking to patients and see what is important to them, and because there's a lot of things that we don't think is all that important, but then when you ask patients, they'll give you a very different answer of the information that should be included. And so I think this is one of the cases, and this is probably one of the best cases, where you really need to bring in users to help you figure out what is less is more, yeah, and what stuff is really important to be in there, and what stuff could be, click here to learn more.
I'm not going to disagree with that.
Well, then let's end it there, because that's probably the last time you'll ever hear those words. Thank you very much.